So with that, I wanted to say thank you and kick off the beginning of our 2021 summit. And with that, I have the great pleasure of introducing our first moderator, and that's going to be Dr. Christina Davidson. So not only is she the TCHMB Obstetric Committee co-chair, but she's also been a mentor and a friend to me for a number of years. So I'm really grateful to get to introduce her. She's a board certified maternal fetal medicine specialist at Baylor College of Medicine, which she joined in 2007. She works at both Bentab Hospital and Texas Children's Pavilion for Women in the Texas Medical Center. For Baylor, she's the vice chair of quality, patient safety, and equity for the Department of OBGYN at Baylor College of Medicine. And she's also the chief quality officer for the OBGYN department at Texas Children's Hospital. In addition to being the OB committee co-chair, she's newly the vice chair of the Society of Maternal Fetal Medicine, Patient Safety and Quality Committee. And with that, I am grateful to turn it over to Dr. Davidson.
Thank you very much, Dr. Epps. And I am honored to introduce our keynote speaker, Dr. Wanda Barfield, who is going to speak on reproductive health priorities and their impact on racial and ethnic disparities. Dr. Barfield is actually currently deployed for COVID response and was not able to be here with us physically today. However, she kindly pre-recorded today's session for us. Dr. Wanda Barfield is the director of the Division of Reproductive Health within the National Center for Chronic Disease Prevention and Health Promotion at the CDC. She is a retired Assistant Surgeon General in the U.S. Public Health Service. Dr. Barfield joined the CDC in 2000 as part of its Epidemic Intelligence Service, where she worked in neonatal and perinatal health and was named Division Director in 2010. Her research focuses on maternal and infant morbidity and mortality, early child health services utilization, improving access to risk-appropriate perinatal care, and advancing the quality of maternal, infant, and reproductive health data for public health action. She has published over 120 scientific articles in these areas. As director of the Division of Reproductive Health, Dr. Barfield has led efforts to provide optimal and equitable health to women, infants, and families through improved surveillance and applied public health research during the critical junctures of population health: pregnancy, infancy, and adolescence. She has built and strengthened numerous strategic partnerships with multiple maternal and child health organizations. Her division currently leads several activities to monitor maternal mortality and severe maternal morbidity, prevent opioid use disorder and overdose among pregnant and postpartum women, and reduce the risk of neonatal opioid withdrawal syndrome and associated adverse infant health outcomes. She received her medical and public health degrees from Harvard University and subsequently completed a pediatrics residency at Walter Reed Army Medical Center and a neonatal perinatal medicine fellowship at Harvard's Joint Program in Neonatology. Before joining the CDC, Dr. Barfield served as a medical officer, pediatrician, and neonatologist in the U.S. Army. So with that, I'm going to turn it over to John, who is going to start our video. And after we watch the video, we're going to go into a pre-recorded question and answer session.
Good morning. I'm Dr. Wanda Barfield, Director of CDC's Division of Reproductive Health. It is such a pleasure and an honor to speak with you today. I have no disclosures. Some of you may know my story, but I'd like to share the aha moment that set me on the path to speak with you today. When I was a child, I was certain I would be a veterinarian when I grew up. It seemed like animals that needed help were somehow drawn to me. I even adopted a squirrel and cared for it. It seemed certain that I would spend my life caring for creatures, both large and small. I didn't realize it at the time, but that dream was possible because of a decision my father had made years before when he was a young man in the tobacco fields of eastern North Carolina. At the urging of his Aunt Ruth, he decided to join the Navy at age 17. That decision changed the social determinants of health for my family. Early in college, I learned something that changed everything for me, though. I learned that Black babies died at a rate twice that of white babies. I was shocked. Why? Because my dad's military service, our family had access to employment, housing, education, and particularly equity in the delivery of health care. So a question formed in my mind: could equal access to care improve outcomes for Black babies? That question led me to a lot of places, including here with you today. What I learned is that the health of people we care for is heavily influenced by the factors that surround them. The health of a mother and baby are heavily influenced by factors that surround them, including our families, our communities, our regions and states, even our countries of origin. The circumstances in which we are born, grow, live, work, and play, the social determinants of health, affect our health and our life. We also understand that certain social determinants have adversely affected the health and lives of Black, Latino, and Indigenous populations. In order to really improve care and outcome for mothers and infants, it's important disparities. Social determinants of health have historically prevented many people from racial and ethnic minority groups from having fair opportunities for economic, physical, and emotional health. These obstacles lead to health disparities. They are social, economic, or environmental disadvantages that put minorities at risk for worse health outcomes. I've listed some of the social determinants that contribute to health disparities here. Later, I'll share work that we're doing to better understand how social determinants of health influence disparities in reproductive health. Disparities in health exist across the lifespan and are sustained across generations. There are significant disparities in preterm births, teen birth rates, maternal mortality, and chronic conditions. In 2018, the rate of preterm birth among African American women was about 50% higher than among white women. As I have shared earlier, racial disparities in infant outcomes are part of what set me on my career path. These disparities persist today. While we've been working to improve outcomes for all infants, this disparity has existed for far too long, and there's still much that we really need to do. Some of the factors that we know that contribute to preterm birth include age, race, socioeconomic status, behaviors like tobacco and substance abuse. Infant health is not just about the baby. It's about the social environment that their pregnant mother is in. We also see that there are significant disparities in teen birth rates. Although teen birth rates have dropped to include historic lows nationally, racial and ethnic disparities still persist. In 2018, the birth rate for Hispanic teens, non-Hispanic Black teens, and Native American Hawaiian or other Pacific Islander teens were more than 2 times higher than that for non-Hispanic white teens. The birth rate for American Indian, Alaska Native teens was amongst the highest for all ages and for all races and ethnicities. There are also considerable racial disparities in maternal mortality for American Indian, Alaska Native, and Black women, who are 2 to 3 times more likely, respectively, to die of pregnancy-related causes than white women. These inequities increase by age and are present at all educational levels. And what makes the numbers overwhelmingly tragic is that data from the maternal mortality review committees indicate that at least 2 of 3 of these deaths may be preventable. There are many factors that impact disparities and put some people at higher risk for poor outcomes. One of the important factors is the variation in the quality of care that women receive. This is particularly important given that we know that nearly half of maternal mortality and adverse events are preventable. Standardizing quality care is very important. A study led by Elizabeth Howell demonstrated that both within hospital and between hospital disparities exist for severe maternal morbidity. Black women deliver in lower quality hospitals than whites, and the quality of care received by women during childbirth differs by race and ethnicity within individual hospitals. Similarly, disrespect or mistreatment during childbirth needs to be addressed. The Giving Voices to Mothers study, which was published last year, looks at the experience of childbirth in the United States. The study found that families of color experience high rates of mistreatment by healthcare providers during birth. Overall, 1 in 6 women, regardless of race, experience mistreatment by healthcare providers during birth. Top experiences of mistreatment included verbal abuse, stigma and discrimination, and delays and refusals in care. Indigenous women were the most likely to report experiencing at least one form of mistreatment by healthcare providers, closely followed by Hispanic, Latino, and Black women. Rates of mistreatment of women of color were consistently higher even when examining interactions between race and other maternal characteristics. For example, 27.2% of women of color with low SES reported any mistreatment versus 18.7% of white women with low SES. Regardless of maternal race, having a partner who was Black also contributed to reported mistreatment. This study shows that adverse maternal and newborn outcomes in Black and Indigenous communities are linked to quality of care. This is particularly significant given that Black, American Indian, and Alaska Native women have the highest rates of death from pregnancy-related complications. Another aspect of maternal mortality rates in the U.S. and an area with persistent racial disparities is chronic disease. DRH's work to reduce chronic conditions in women of reproductive age focuses on 3 main areas: diabetes, heart disease, and mental health and opioid abuse. All of these conditions impact women of reproductive age. Preventing them would improve pregnancy outcomes and women's health throughout the life course. And of course, there's the challenge that's facing every single one of us right now, COVID-19. With every public health challenge that comes up, we think about what is the effect that will be for our most vulnerable, particularly pregnant women and infants. CDC is supporting multiple efforts to understand the impact of COVID-19 on pregnant women and infants. This includes providing support and resources to state, tribal, local, and territorial public health agencies to add a COVID-19 questionnaire supplement to existing maternal and infant health surveillance systems. One example is the Pregnancy Risk Assessment Monitoring System, or PRAMS, which routinely collects population-based data on maternal behaviors and experiences before, during, and shortly after pregnancy. The questionnaire supplement collects data on the effect of COVID-19 on pregnant and postpartum women and infants. Findings will inform federal, state, local, tribal, and territorial public health responses to support pregnant and postpartum women and infants. CDC is also supporting studies with the Icahn School of Medicine at Mount Sinai, the University of Washington, and the ESPI Electronic Cohort Study. in order to better understand the characteristics and impact of COVID-19 on pregnant women. There are physiologic changes in pregnancy that could increase the risk for severe illness, including but not limited to increased heart rate and oxygen consumption, decreased lung capacity, and the shift away from cell-mediated immunity. It is well known that severe disease has been associated with other viral respiratory infections during pregnancy. Although initial reports had been unclear regarding COVID's impact on pregnant women, recent studies have helped to define this much better. Based on what we know at this time, CDC has adjusted its language, saying that now pregnant women are at increased risk for severe illness from COVID-19. Pregnant women with COVID-19 might have an increased risk of adverse pregnancy outcomes, such as preterm birth. We also know that Hispanic and non-Hispanic Black pregnant women appear to be disproportionately affected by COVID-19 infection during pregnancy. We must make sure that all women have access to the care that they need and are aware of their potential risk for severe COVID illness. Thankfully, we now have authorized and recommended vaccines to prevent COVID-19 in the United States. CDC and the Independent Advisory Committee on Immunization Practices, ACIP, have provided information to assess pregnant people with their decision to receive COVID-19 vaccine. Currently, there are limited data available on the safety of COVID-19 vaccines for people who are pregnant. While studies have not yet been done, based on how mRNA vaccines work, experts believe that they are unlikely to pose a risk for people who are pregnant. mRNA vaccines are not live virus vaccines and do not cause genetic changes. Currently, there are no data on the safety of COVID-19 vaccines in lactating women or on the effects of mRNA vaccines on the breastfed infant or on milk production or excretion. However, mRNA vaccines are not thought to be a risk to the breastfeeding infant. People who are breastfeeding and are part of a group recommended to receive a COVID-19 vaccine, such as a healthcare personnel, may choose to be vaccinated. At this time, healthcare personnel are recommended to be among the first to receive the vaccines because they are at increased risk of exposure to the virus that causes COVID-19. Healthcare personnel who are pregnant may choose to be vaccinated. A conversation between pregnant patients and their clinicians may help them decide whether to get vaccinated. It's important also to note that pregnant patients who decide to get vaccinated should continue to follow the current guidelines to prevent the spread of COVID-19 after they are vaccinated. I'd also like to encourage anyone getting the vaccine to use the Be Safe after vaccination health checker. Be Safe is a smartphone-based tool that uses text messaging and web survey to provide personalized health check-ins after you receive COVID-19 vaccination. Through VSafe, you can quickly tell CDC if you have any side effects after getting the COVID-19 vaccine. Patients who receive the vaccine during pregnancy or within 30 days of becoming pregnant will receive additional follow-up, including 2 to 3 calls during pregnancy and the postpartum period. Any adverse event post-vaccination can also be reported to VAERS and Vaccine Safety Data Link. Participation in VSafe makes a difference. It helps monitor the safety of COVID-19 vaccines in real time or near real time and include any impact on pregnancy. If any serious health problems are reported, they can be quickly investigated by CDC's medical experts and scientists. So, what is CDC doing to address inequities and improve maternal and infant health? Because maternal mortality is a multifactorial problem, we really need to look at robust, detailed data to better understand and prevent these deaths. Maternal mortality review committees, or MMRCs, are part of a multidisciplinary process where a committee at the state or city level identifies and reviews maternal deaths that occur within 1 year of pregnancy, regardless of the outcome of the pregnancy. MMRCs get the most detailed, complete data on maternal deaths, including information about social determinants of health. CDC has a long-standing partnership with Emory and states on using geocoded Maria data to help bring information about the community a woman lived in, her community vital signs, into the discussion of her death by the MMRC. CDC and Emory have a formal pilot activity through Illinois and North Carolina's MMRCs to understand committee readiness and effective implementation strategies. Some states are also moving forward with their own pilots, showing an eagerness to engage in structural contributions to disparities in pregnancy-related mortality. In addition, Maria now allows committees to document determinations on whether discrimination and racism contributed to a death based on common definitions developed by the work group. These efforts are helping us to collect data that can then translate into effective programs that address factors contributing to maternal death. One of the things that you can do is to work with your state's MMRCs and connect community partners to the MMRC. Getting involved will help us get more, better, and faster data so that we can prevent tragic outcomes in the future. We're also collecting data on emerging topics through PRAMS, the Pregnancy Risk Assessment Monitoring System. PRAMS collects data on state-specific population-based data on maternal attitudes and experiences before, during, and shortly after pregnancy. A questionnaire supplement on prescription opioid use during pregnancy was used by states in 2019, and initial findings released in July of 2020. In addition, PRAMS has developed a COVID-19 questionnaire, which I mentioned earlier. Moving forward, the team is planning to work on enhancing PRAMS data collection and data dissemination as it relates to the social determinants of health. Strengthening data is just one part of CDC's integrated strategic approach to addressing maternal mortality and improving women's health across their reproductive years. Opportunities to prevent pregnancy-related deaths occur before pregnancy, at every stage of pregnancy, and immediately after. CDC funds the efforts of 13 state perinatal quality collaboratives, or PQCs, which are state-based initiatives that aim to improve the quality of care that mothers and their babies receive, as well as the national network of PQCs to expand the reach of lessons learned on a national scale. As we talked about earlier, variations in quality of care contribute to maternal mortality and morbidity. We'll look more closely at the role that PQCs play in quality improvement later in this presentation. Another initiative that we have is CDC Locate, which helps states and other jurisdictions monitor systems of risk-appropriate care in their regions, enabling them to show the capabilities and staffing services within levels of maternal and neonatal care among delivery facilities. I'm also proud to share that we have recently launched The Hear Her campaign, with support from CDC Foundation and Merck for Mothers. The goal of the campaign is to raise awareness of potentially life-threatening warning signs during and after pregnancy and improve communication between patients and their healthcare providers. The campaign directly reaches pregnant people and their support networks. On the site, we have information about pregnancy-related deaths in the United States, personal stories from women who have experienced pregnancy-related complications, captured in video information about the urgent maternal warning signs from the Council on Patient Safety in Women's Healthcare, resources for pregnant and postpartum women, their support systems, and healthcare providers to facilitate conversations. There's also social media posts and graphics that you can share through your own channels. I would encourage all of you to go and view the PSAs and testimonials on this site if you haven't already. They are really quite powerful. Now, let's talk about the role PQCs play in providing health equity through quality improvement. Better data informs better practices, and our perinatal quality collaboratives, or PQCs, are continuing to build networks for rapid dissemination of best practices and implementation of effective initiatives to improve outcomes for pregnant women and newborns. PQCs play a critical and unique role as they are on the ground and able to enact change on a facility-based or local level, but are also able to scale up improvements statewide and engage a large network of stakeholders. They have the power to change the culture of care. As published in a recent article, some state PQCs have been able to effectively use collaborative quality improvement model, and there are many examples of successful PQC initiatives improving both maternal and infant health. Some examples on the maternal side include the Illinois Perinatal Quality Collaborative, or ILPQC, and they improved the timeliness of treatment for women with severe high blood pressure, increasing the percentage of patients treated within 60 minutes from 41% at baseline to 79% in the first year of the project. The Northern New England Perinatal Quality Improvement Network improved care for women with opioid use disorder, increasing access to medication-assisted treatment and breastfeeding counseling over a 13-month time period. And the Perinatal Quality Collaborative, or California Maternal Quality Care Collaborative, known as CMQCC, reduced serious pregnancy complications among women with severe bleeding during pregnancy or delivery, decreasing rates by 22% at baseline to 18% in the last half of the 14-month project. And on the infant side, the Perinatal Quality Collaborative of North Carolina reduced central line associated infections among newborns in neonatal intensive care units through the state by 71%, with sustainment 1 year later. The Ohio Perinatal Quality Collaborative improved use of antenatal steroids to accelerate lung maturity for preterm infants, with greater than 90% administration of antenatal steroids documented in hospital records for births from 24 to 34 weeks gestation. They also developed a toolkit with quality improvement interventions to promote reliable systems for appropriate administration of antenatal steroids. And the Perinatal Neonatal Quality Improvement Network of Massachusetts optimized the non-pharmacologic management of opioid-exposed newborns and reduced hospital length of stay and opioid pharmacotherapy for infants with neonatal withdrawal syndrome using an Eat, Sleep, Console Care tool. And of course, There's the Texas Collaborative for Healthy Mothers and Babies. I'd like to highlight some of TCHMB's accomplishments in 2020, including developing and distributing a reference sheet on public health care coverage programs for those working with uninsured women, demonstrating commitment to the reduction of healthcare disparities through the Health Equity Work Group, and ongoing collaboration with Texas AIM, including the Maternal Early Warning Systems, or MUSE, and logistical facilitation of their Severe Hypertension in Pregnancy Patient Safety Bundle Learning Collaborative. It's also important to talk about what we can all do in order to. I'd like to share a recent story on disparities in infant mortality. This study examined 1.8 million hospital births in the state of Florida between 1992 and 2015 and found that Black babies have better outcomes when they're cared for by Black doctors. The study found that when Black physicians were in charge of the birth of Black babies, their mortality rate was cut in half, and when Black newborns were cared for by white doctors, they were about 3 times more likely to die in the hospital. The race of the doctor caring for white babies didn't significantly change the likelihood of the newborn survival. The study also found that these effects were stronger in more complicated cases and when hospitals deliver more Black babies. The authors noted that Black babies were more likely to have complex medical needs. They were in higher risk for eclampsia, preeclampsia, preterm delivery, and social determinants, such as socioeconomic inequality. The study suggests that for Black infants, physicians from the same racial group deliver better quality of care than white physicians. This study gives us more evidence that we need to raise awareness among all healthcare providers and work on addressing bias and institutional racism. We all need to do more to protect the health and well-being of women and children of color in the United States. We need systematic change to address the societal factors that surround women and babies that we serve, but we also need work directly to improve maternal and infant health. In 2018, the American College of Obstetricians and Gynecologists released a committee opinion about the importance of social determinants of health and cultural awareness in the delivery of reproductive health care. Here are a few key recommendations that all of us, whether we're practicing physicians or not, can implement with the people that we serve. Acknowledge that race, institutionalized racism, and other forms of discrimination serve as a social determinant of health. Recognize that stereotyping patients based on presumed cultural beliefs can negatively affect interactions, especially when the behaviors are attributed solely to individual choices without recognizing the role of social and structural factors. And encourage change that promotes safe and healthy living environment. And beyond that, work on advancing equity through workforce development, diversifying the healthcare workforce has been shown to help improve access to health and the quality of healthcare for minority groups. We should provide opportunities for our teams to learn and maintain the knowledge and skills to advance health equity and ensure that our teams and organizations reflect the demographics of the populations that we support. This includes supporting young people as they pursue the sciences and mentoring young adults and early professionals. Martin Luther King Jr. recognized the importance of health equity decades ago when he said, "Of all the forms of inequity, injustice in health is the most shocking and inhumane. That's why our progress on these issues, reducing maternal mortality and addressing the social determinants of health that can lead to such tragic outcomes, is so important. We need to take action on many levels to really begin dismantling disparities. It begins with each one of us. I know that addressing implicit bias and structural racism and the work that we do as healthcare providers is incredibly difficult. We all have biases, and as health providers, we need to dig deep to use the fundamental skills that brought many of us to the profession we are in. We need to bring listening, compassion, and empathy and build relationships and trust with the families that we serve. Yes, that we serve. As health professionals, we have to acknowledge that racism exists everywhere and take conscious and intentional action against it. The way that we can truly provide optimal, equitable, and quality care to those who need it the most. Thank you.
Well, we are so grateful to Dr. Wanda Barfield for pre-recording her talk for us. It was full of so much helpful, important information. And because she wasn't able to be with us live today, she also pre-recorded some questions that TCHMB sent her. And so we sent her questions and we are going to play her responses to them. Some of the questions align with questions that we've already seen in the chat. However, if you have additional questions that you'd like to ask her, she has graciously offered to answer the questions that may come up during the session. And we'll be putting together a Q&A document that will be posted on the TCHMB website after the summit. So we will now play her Q&A session.
I would love to hear more details about the slide on page 15 of her attached presentation. Specifically, what information does Maria use to document discrimination and racism, and what programs have been created as a result to address those factors contributing to maternal mortality? The CDC Foundation co-facilitated a work group of Maternal Mortality Review Committee members, or MMRCs, and subject matter experts to understand and capture bias as a factor that potentially contributes to maternal mortality. The work culminated in the addition of discrimination, interpersonal racism, and structural racism as a standardized data captured in Maria, with new job aids to define these three contributing factors, and orientation on how to appropriately detect and document these contributing factors. To date, MMRCs have shared that they have used Maria tools to document evidence of discrimination by training committee members to identify keywords, phrases, and situations that provide evidence of discrimination. A second question: are there examples of ways that hospitals, along with their partners, have been able to identify needs and address or impact social determinants of health for a patient delivering in their hospital? Well, some hospitals are including information on social determinants of health directly into patient records, such as housing insecurity. For example, the Louisiana Perinatal Quality Collaborative has developed a respectful patient partnership driver that encourages best practices, including protocols for hospitals to document verbal screening questions related to social determinants of health, substance use screening, and other evidence-based screening. They've also designed and tested standardized delivery discharge tools, providing support for counseling and coordination during and after childbirth that met literacy and language needs, and ensuring that women have appropriate follow-up care and understanding warning signs or when necessary to return to their health provider. The Illinois PQC also promotes strategies to improve birth equity, including utilizing the ILPQC Social Determinants of Health Community Resources Mapping Tool to link patients with resources, including affiliated outpatient prenatal care sites and hospital OB units. Screening all patients for social determinants of health needs during prenatal care and at the delivery admission, as well as linking to resources and services, is another example of what Illinois PQCs are doing. A third question: are there models of coordination partnerships between outpatient and inpatient care to address social needs and racial disparities? There are models of coordination and partnerships between clinical care and social needs that we all need to become more familiar with to support evidence-informed screenings and connections to care. I'm a pediatrician, and pediatricians coordinate around outpatient and inpatient care all the time, particularly with infants with complex medical and social needs. I think it lies in our effort and also our resources. How much effort is placed in identifying support for families that don't have the resources or the time to call or transport themselves. Providers need to make sure that they are thinking this way for all of their patients, not just those with the most complex health needs. These warm handoffs to community partners can be a challenge, though. Patient navigators are often led to better outcomes with inpatient and outpatient follow-up and response by the patient. However, financial resources are often limited. With respect to partnership coordination to address racial disparities, it's not just about the coordination of possible social needs, because Black women with a college degree are still more likely to die from complications than a white woman with a high school education. Identifying differences in care that may be associated with structural racism and implicit bias are also key factors in addressing disparities. Hospital-based quality improvement teams can also work on how to best collaborate with partners and patients in the community to better understand how to address these factors. The ideal is that the community and patient partnerships lead hospitals in their quality improvement work. A fourth question: based on the Florida study in slide 26, what are your recommendations to address the observed racial disparities based on race of the physician, specifically related to the health workforce, medical training, and continuing education of physicians? It is interesting that you ask your question that way. What the data showed was the issue was not the race of the physician, it was the race of the baby that made the difference in outcomes. The question is, how do we work so that all physicians provide equitable care independent of the race of the baby, or more specifically, the mother? There is an urgent need to continue research in this area to better understand why white physicians may be providing suboptimal care to non-white patients. Systemic bias in optimism of outcomes, perception of pain, variation in perceived viability, and differences in severity of illness all play a role. Secondly, the same factors that drive disparities in infant health outcomes also drive disparities in medical and nursing training and education. Everyone in the health field has a role to play in addressing the diversity of the healthcare workforce. Simply put, we need a health workforce that represents its patients. This goal would better provide clinical leaders and mentors with shared lived experiences as their patients that are better able to model quality care for all patients.
Well, once again, a huge thank you to Dr. Barfield and her team for preparing this for us, despite her commitments and obligations to the COVID pandemic. And again, any additional questions you have, please continue to put in the Q&A and we can send them to Dr. Barfield. And if there are questions that are specifically directed to TCHMB, please specify that as well. And we are happy to answer throughout the day. I think you'll find the answers to a lot of these questions throughout the remaining program. And I'm going to turn it over to Dr. Pat Ramsey now.
All right, thank you, Christina. Very excellent discussion. And again, put those questions in the chat box.